Okay, so we're going to get started this session. So thank you for being with us in this sunny Friday afternoon. I'm Julie Bruno. I'm from the University of Montreal, and we'll get started. We have 3 amazing presentations, 20 minutes each, and then a period for questions. So we'll take some questions, some for clarification in between presentations, but then we'll keep the discussion for the end.
Great. Well, welcome everybody to this session. This session is what we would call in the UK enhanced harm reduction. It's the sort of next generation of harm reduction. Where do we take harm reduction beyond the core interventions that I think have become really well established? And we've got 3 great speakers who are going to take us looking at stimulants, looking at drug checking, and looking at safe supply, which is very close to my heart. So we're really looking forward to these, all of our hearts, in fact, and this is, I think a really exciting opportunity to have a conversation about these 3 topics. And we're going to start with a topic that's also particularly close to my heart, which is the issue of stimulant drugs. Ernesto has been part of the team that worked with UNODC HIV team to write the jointly published guidelines by UNAIDS, WHO and UNODC on people who use stimulant drugs. And Ernesto is going to particularly talk about the area of smokable cocaine, particularly from a Latin American and Caribbean perspective. Ernesto works with the Latin American network of people who use drugs and is someone I'm very happy to describe as a comrade and friend.
Thanks, Matt. Hello, everyone. I'm really glad to be here and hope you had a good lunch. Hope it's not too boring, so we don't fall asleep. I'll try to do my best. So, as Matt said, I'm going to speak specifically on smokable cocaines. I know that it's a matter that concerns us in Latin America specifically. This presentation comes out from a document we published with the Transnational Institute in 2019. And smokable cocaine markets in Latin America call for sustainable policy response. It was supported by the GDPD grant and Open Society Foundations. So we had a working group on smokable cocaines. We took advantage of a couple of regional conferences, the Latin American Drug Policy Conference and the Drug Policy Conference in Atlanta, and the other one was in Dominican Republic. So we work in 10 different Latin American and Caribbean countries, more than 20 specialists, 2 international workshops, and we wrote down 1 regional report in Spanish and in English. So just to start a little bit about smokable cocaines, because we talk about smokable cocaines and not crack cocaine specifically, because in the cocaine-producing countries that you see there in light green, in South America, Colombia, Peru, and Bolivia, people don't get crack, they get base. So it's before cocaine is produced. So there's a differences in the substance itself and the way people use it, But I'm not going to talk about the traffic and stuff. I'm going to keep going. First of all, there's definitely a lack of research, a lack of data. We think it's definitely related to stigma and discrimination towards people who use smokable cocaines. In fact, we thought after we published this paper, there are a lot of funding and processes were going to come up to start working on smokable cocaines in Latin America. I assure you it hasn't happened yet. There's some reports done by the Commission on Drug Use from the OAS, the Organization of American States. There's a lot of data in Brazil. Brazil definitely is the country that has more data on people who smoke crack specifically. On the right, your right top, there's the Pesquisa Nacional sobre Uso de Crack. There's the national research on crack use. They interview more than 300,000 crack users in Brazil. So they have a lot of data, but Brazil itself, it's a continent. We say it's 200 million people in that country. Uruguay has some papers. I wrote a paper from a small research I did in Costa Rica in 2015. So as I said, there's case studies in different countries and use of qualitative methods to work with hidden populations. The lack of data also pushes us to use more ethnographic and qualitative data. It's definitely a way to go to start thinking also on how we can make more quantitative data and have more epidemiological data on people who use smokable cocaines. I also want to mention after this report, these two important documents you should check. One is written by the UNODC, the United Nations Office on Drug and Crime. It's the HIV prevention, treatment, and care and support for people who use stimulant drugs. This is a really helpful document. Matt and Monica here could talk more about it, definitely, no, because it's related to a whole group of workshops that UNODC had been pushing and carrying in several areas of the world. We're still waiting, and we're going to start doing it in Latin America very soon enough. And the other one is done by Mainline Health. It's a Dutch organization that's called Spill Limits. They look at different good practices and programs around the world that deal with stimulants. Specifically in Latin America, there was on Brazil and Uruguay on people who smoked cracks. So to understand a little bit about what's smokable cocaines, this graph shows how cocaine is produced and its different moments in this process from the coca leaf till it gets done by crack. No? All the circles on your right, on our right, no? It's part of the process that you can smoke. No? At the end, most of the countries that we live in, no? If you're not here from Colombia, Bolivia, or Peru, or Ecuador, no, we might get crack, definitely. No? So we get the last one of them. Crack could be produced with ammonia, sodium bicarbonate. It is more common in Latin America to be produced with sodium bicarbonate. And that's a whole thing also we should think about and discuss if we want to do harm reduction process. But also, as I said before it, you have the bases, different kind of base, no? And the way that smoke, it's also different. We also searched some of the quality and adulterants in smokable cocaines in different Latin American countries. Also showing, this is from the OAS, the Organization of American States. You know, the samples are very different. For example, in Chile, they had like 60,000 samples. No? In Argentina, it was really smaller than that. In Uruguay, but also most of these samples are also what police seized. You know? So it's drugs that are not really in the market yet. We need really to do more research from drugs in the market with people who use drugs. You know, drug checking systems are not common at all in Latin America. We have a few experiences in Brazil, in Colombia, and in Mexico, a little bit in Uruguay and Argentina, but it's not a common practice yet. You know, I'm not going to talk more about drug checking, but definitely it's a harm reduction intervention that should be there. Also thinking, at the end, what you see is phenacetin and a lot of caffeine. It's really common in this, in crack and these substances. The price, I'm not going to go through that much. The only thing I want to say is, as we are so close to the areas that cocaine is produced, it's really cheap. Yeah? Cocaine is cheap, crack is cheap, but also there's a stigma that people who use crack are poor people. This is the drug for poor people, no? So stigma increases also, and the violence towards people who use cracks, it's also really common. Not only by police or the state itself, but in society in general, you even see people justifying or acknowledging that you can be violent, you know, and harm people who use crack or smokable cocaines. So the ways of use, you know, crack is smoked in different ways around Latin America. They use cans, they use metal pipes, glass pipes, you know, and the one on the left bottom, it's for pasta base, it's for base, that is pretty particular how they do it. And it also gives us some challenges on how to introduce paraphernalia or different kind of ways. Now, in fact, this pipe you see here, it's a bazuco pipe. Bazuco, it's also a way to call vase. In fact, it means basura sucia de cocaína. So it's rubbish, dirty rubbish from cocaine. You know, the same words that they use, it's also really stigmatizing words. You know? But you see, it's a really artisanal and a really complex way to do these pipes. You know? So in Colombia, for example, we were thinking, or we were discussing with our peers how to introduce paraphernalia in pipes. They say it has to look something like this, because the pipe itself, like, you can ensemble it and smoke where it's inside. You know? So that has to be taken in account. So there's many different kits for use or paraphernalia so reduce the harms, no? Mainly the reducing harms on lips, mouths, throats, and lungs. No? As you saw, some of the pictures has this Brillo as used as a filter. No? This Brillo, when you turn it up, it's such a bad metal that it just breaks down, and you get all this burning metal in your mouth and in your lungs. And we have seen, there's no research about that, but at least in my country, in Costa Rica, young crack users with a really bad lungs, pulmonary health, that is related to these metals that it comes. So what you see in the top right is just a small tube, plastic tube that they give out in Brazil, mainly in an area I will show you, because there's also a lot of organized crime dedicated to sell the pipes. So you also don't want to get in. There's a lot of violence, and then I'm going to get to that, because most of it is related to the war on drugs, but it has to do with just put a mouthpiece in your pipe, in your cachimbo, as they said. The one on the left, on the bottom, I got it from Porto and the Harm Reduction Conference in 2019. This is the Medicines du Monde kit, and the one on the right, on the bottom, it was in Brazil, also in Sao Paulo, and it was given out mainly to trans women. So you see the lip balm, that is a important issue, to have something to put something on your lips. Had also messages like, I love you myself, treat well, so it's also engaged with the people, because at the end, what this is more important as much as reducing the harms related to the way you use of these metals that I said, is definitely a way to engage with people who smoke cocaine, and outreach interventions. Most of the people we work with that gave out this kind of kits said, the most important thing is when you give out these kits, people come back. So you definitely want them to be engaged in the program, and this kind of harm reduction interventions are one of the best ways to go through that. So there's also pharmacological substitution trials. There's a little bit with cannabis that is really interesting. There's a couple of papers published a long time ago in Jamaica and in Brazil. There's some amphetamine-type stimulants done in St. Lucia. Maybe some of you know Marcus Day. Well, Marcus Day helped to write also the guidelines for UNODC. Coca mild stimulants in Colombia. There was a trial that was they tried to do it in Bogota many time ago, but it didn't work much. And there's also some proposals with entheogens like ayahuasca or iboga, but it's mostly abstinence-based proposals. So I'm getting to the big part. Users, people who use crack. As I said, it's one of the most stigmatized and criminalized and violented drug user population. I put in here two examples. In Bogota, a neighborhood called El Bronx, and in Sao Paulo, a neighborhood called Cracolândia. Cracolândia, it's crackland. El Bronx is named from the Bronx. So you see a lot of homeless people. Most of these areas is also territories by organized crime. So both in Brazil and in Bogota, they put on some interventions that I'm going to try to show really fast because I only had 8 minutes now. It's important to start saying that harm reduction programs, low threshold programs we call it, are part of a bigger networking and programming. So there's several principles that have been done. This document from Open Society Foundations in Portuguese tries to resume and push organizations to work with these principles. Proximity, be there with people. Territoriality, be where people use. Advocacy, address conditions of stigma, marginalization, and discrimination. Intersectoriality, articulate, coordinate with others. Don't do a single program. Try to get people to go to different areas. And networking. So there's several community-based organizations in Brazil that we work with. Many of our peers from the Latin American network, People Who Use Drugs, are part of these organizations. So they're also community-based organizations run by drug users. In Recife, Escola Libre de Reducción de Daños. We have a nice project right now to put out a virtual training on harm reduction in Latin America. Redes da Maré in Rio de Janeiro, or EGLA in Sao Paulo, that is one of the oldest, and have these places where drug users can come and work together. But I wanted to talk about these programs in Bogota that is the Centros Móviles. It's mobile centers for drug use. They have multidisciplinary teams. They have at least 10 mobile units in 5 different places. So they work directly, also connect. These mobile units had medicine, but also dental care, for people who smoke, smokable cocaine, crack, or base. The mouth health and all related to teeth, it's really important. They also work with centers. Consultorio na Rua, that is like the street consultory. Also, this is in Brazil. There's many of them. It went back a lot with the last government from Bolsonaro. Or the Brazos Abertos, that was the biggest program ever done in Latin America, with all these secretaries from the city of Sao Paulo and even the state. So they put out this program that they basically have a lot of stuff, but the most important thing was housing and job opportunities. So crack users could get 13 or 15 different job opportunities a day. So they work for a day and they get paid in cash, but also get some housing. So the government rented full hotels close to this area of Cracolândia that I showed, so people could go to sleep. They evaluated the program. It was completely successful. Sorry, everything is in Portuguese, even though I speak Spanish. But it's they valued like really positive. They also said they reduced the amount of crack and smokable cocaine, and the things they lacked the most, the interventions they valued the most of the better was moradia, that's housing, and trabajo renda, that's job opportunities. So what we know, it's definitely these 2 things. Well, and support was the third. I'm talking about the graph on the bottom right. That is definitely important. So I showed this because in Latin America we talk about broader spectrum harm reduction. As I said with the kids or this stuff, it has to be close to other programs. And if you give a kid for, I don't know, say for crack smoking to a person who lives in the street, it would help them in that area. But you definitely need to relate and engage in the broader programs and networking. So as I showed, Bogota El Bronx in 2000 and, okay, I lost the last number there. So it's 2015 in Bogota. After the mayor changed in an election, the first thing the next mayor did was to close the CAMAT program, and raided the area. Police raided the Bronx area. The same thing happened in Sao Paulo. When they changed in 2017 their mayor by political elections, the first thing that this politician did was closing open arms program and raided the Cracolândia area. And I showed this because at the end, you value and it's evaluated programs, best practices, but there's a political issue in Latin America driven by the war on drugs that don't allow these programs to continue. So definitely thinking about stigma, criminalization, it's part of why we talk about harm reduction from a broader spectrum. So just to close, 3 minutes and 23, I've been going really fast. I want to show this infograph. RD, reducción de daños, harm reduction. This comes from Brazil. I put it in English, because it says several principles also how we think harm reduction in Latin America. Keep focus on people, not the substance. It's a collective construction of practices and knowledges. The relations with drug is not only through dependence, care beyond drug use. It deals with people, human rights. It's an integrated and human approach toward diversity. It's a process, not a quick response. It's particular. It doesn't have one formula. So many of us that do harm reduction or believe ourselves as harm reductionists, that is kind of the quote. I have that from a book we wrote with RIOD, that is the Ibero-American network that works with drugs. There's no only one harm reduction process. At the end, we have to build the interventions with the same people we work with. The same users know what they need and have to be part of this process. But also, we consider ourselves more agents of social transformation. Most of all, even considers ourselves as politically militant on harm reduction. First, beside giving out kits or beside giving out housing, it's a political aspect. We have to deal with violence. We have to deal with criminalization. We have to deal with women who use drugs and take their children out from them, you know, because it's a political aspect, and we have to work towards this space of ethic of care. I love that because that's what Brazilians tell me a lot when you ask, what's harm reduction for you? It's an ethic of care for yourself and care for others. And we think about ethics, there's not only one way. You always have to understand, listen, put attention, analyze the situation, and go and do something that really works for people. And best of all, or if we could, have sustainability in this intervention. And I think that's it.
Fantastic. I would not expect anybody speaking about stimulants not to speak fast. I think it's highly culturally appropriate. So thank you very much, Ernesto. Look, and I thank you also for mentioning the UNODC training process that we've been working on with Monica and her team. I think it's important to acknowledge that the guidelines actually come from 3 UN divisions. So it's UNODC's HIV team, WHO with the championing of NET particularly, and then also UNAIDS. And having the backing of these 3 UN divisions when you go around the world as trainers, community-led trainers working alongside UN staff, often sponsored by a range of different UN departments in country, with often the Ministry of Health as well. These are really catalytic training events with these guidelines really starting to give permission to people to undertake harm reduction practice with people who use stimulant drugs. So look, I think it's a really exciting collaboration around what does community-led mean in practice. So do you want any questions at this point that people want to ask Ernesto, any issues of clarification or issues that initially? Monica? Oh, you were, sorry, I thought you were moving your microphone. Anybody else want to ask at this point? All super clear? Great. You'll get Lisa.
All right. So just as a note, if you have questions and you don't want to forget that, then put them in the chat, and then we'll keep them for the end. So it's really my pleasure to present Gillian Colla. And I was playing with the tablet, and I lost her CV, but she's so that's good, because I know her. She's from Canada. She's a community-based researcher, and she's been very important in the field of safer supply, and then she's going to present about safer supply evaluation. Thank you.
Thank you so much, Julie. Awesome. So thank you very much for having me here today. My name is Gillian Colla. I'm from the Canadian Institute for Substance Use Research at the University of Victoria. And just to start off, I just want to acknowledge Canada is a very large country. Much of the research I'm going to be presenting to you today is going to come from 2 provinces, British Columbia and Ontario. And so the research that I'm presenting has taken place primarily on the traditional and unceded territories of the Algonquin people in the area that is now known colonially as British Columbia, as well as on the traditional lands of the Anishinaabe, the Haudenosaunee, the Huron-Wendat, and that are covered by treaties dating back to 1792 in what is colonially known as Ontario. I think in addition to acknowledging the lands on which we inhabit, that we're conducting our research and that we live, it's very important to also acknowledge how drug prohibition, drug policies, and drug laws in Canada have been used to maintain colonial relationships and build on colonial histories of dispossession and displacement in Canada. This has produced social and health inequalities that disproportionately impact Indigenous communities, as well as Black, Caribbean, and African communities in Canada. And this is important, I think, for the topic today because the drug toxicity overdose crisis that we're facing in Canada is also disproportionately impacting First Nations, Métis, and Indigenous people across Canada as a result of both these historical and continuing impacts of colonization today. So just to jump right in and start off, I want to say from the beginning that safe supply is a term without a definition. It's a term with many definitions. Depending on who you talk to, the definition will be quite different. So just to situate us somewhere, we'll define safe supply as a regulated and quality-controlled psychoactive substances that traditionally have been accessible only through unregulated drug markets. I usually will cite Kaput Woods Safe Supply concept document here that came out in 2019 that does very, very good work at laying out some of the groundwork for what a lot of communities, clinicians, researchers across the world had actually been moving towards for quite some time and have contributed towards the philosophical ideas underpinning what we're often talking about as safe supply today. Much of my presentation and much of the work being done in Canada really focuses on opioids because of the context of the drug toxicity overdose crisis that we're facing. However, I think it's important to note, and Ernesto was a very good introduction in this way, that it's also applicable to stimulants, psychedelics, and hallucinogens. And philosophically as well, I think it's important to note how safe supply one of the things that it does is it actually challenges policies, our drug policies that are rooted in and based on prohibition approaches, because it locates the problem not in the individual taking drugs, but in the lack of market regulation that leads people to having to choose to consume drugs that are of unknown dose and composition. It also challenges this idea that people who use drugs should be stigmatized, criminalized, or deemed to be disordered due to their drug use by, again, focusing in on the market factors that surround drug consumption. Now, just really quickly, because I think most people here are very aware of the very devastating drug toxicity overdose crisis that we're facing in North America. But I think that one of the things that often gets missed is just how quickly this exploded. On the left, you can see graphs from British Columbia. Just 10 years ago, we were in the realm of a couple hundred drug toxicity deaths, 334 in a population of about 5 million. That has exploded to close to 2,400 deaths last year. In Ontario, which is a sizably larger population, 15 million, we had around 585 deaths 10 years ago. This is up to 2,500 last year, which is actually a slight decrease when in 2021 we hit almost 3,000 deaths in Ontario. And it's important to really ensure that we locate this problem in the shifting of the unregulated drug supply from heroin to fentanyl analogs. Really, this graph where you see that blue line shooting up starting around 2015, 2016, this is Ontario data based on coroner's postmortem toxicology. Almost all of the excess deaths that we're seeing now over and above 10 years ago are due to fentanyl. And we really, I think, are going to have to focus in on this drug market problem if we're going to have any impact whatsoever on the absolutely catastrophic levels of death that we're seeing in North America right now. So why safer supply? Why are we talking about this? Well, clearly, the graphs that I showed on the previous page really are a good part of why safer supply has exploded within Canada, the need to do something to intervene in this crisis. However, I think it's also important to recognize that some of the options that we had available from people through opioid agonist treatment programs weren't always the most effective or the most desired by communities of people who use drugs even prior to the current overdose crisis that we're facing. In Ontario, if you look at rates of retention in OAT treatment, so methadone and buprenorphine primarily, you'll see that on average people are retained for about 6 months in treatment. This also elides the fact that for a lot of people, they're not currently interested in OAT. And also, unfortunately, based on our data in Ontario, we know that a full third of people who are dying of drug-related overdose deaths don't actually have an indication of an opioid use disorder or a previous encounter with the medical system for something to do with substance use-related causes. So it's really this large group of recreational and occasional users who are also at incredibly high risk of death. I will say right from the get-go, unfortunately, our current prescribed safer supply programs are not actually hitting this group at all, and we don't have very many options for this group of people. It's also important, I think, to note here that we often don't talk about drug use and pleasure, and the way in which, especially because we have, very medicalized views of drug use, because we really look at people who are seeking treatment or harm reduction-related supports, people use drugs because they feel good, because they provide euphoria and pleasure. And this is something that has been really, really difficult to talk about within treatment landscapes. And I think one of the interesting things that Safer Supply has done is it's opened up an ability to have this conversation conversation about pleasure within drug use and what might be the role of safer supply in pleasure. And just acknowledging here that this is also an incredibly difficult conversation to have in the midst of thousands of people dying from drug use every year. So in terms of conceptualizing safer supply, in North America, the chronic relapsing brain disease model of addiction is very, very prominent. I think that safe supply poses a very interesting challenge to this model. And it really introduces as well this ability for us to think about regulatory models beyond prohibition and beyond what we have had available to us until now. So currently, the models that I'm going to be talking about a little bit today are primarily prescribed safer supply programs, and I'm going to talk about why in Canada that's the options that are available to us and what we've been doing and what we've been using. But there's also other models here, and I would invite us all to start thinking about and imagining the way that we could do drug policy differently, and the ways in which we could start thinking about regulation of drug markets in a way that starts moving beyond this 50-year very failed experiment with prohibition that we've had, including buyers clubs, compassion clubs, and fully regulated models for the purchase and distribution of drugs that are currently illegal. So in terms of different modalities of Canadian safer supply programs, and I included that quote from a prescriber there because I think it basically describes, you know, we're doing the best with what we got. I think we all acknowledge that it's not an ideal situation. It's an attempt and very much a crisis intervention attempt that has all of the trials, misses, and occasional successes that comes along with that type of an attempt. So we have had injectable opioid agonist treatments in Canada since 2009. And I think one of the things that's really important to recognize is probably our national shame that we never ever managed up until the current crisis to expand injectable opioid agonist treatments beyond a very, very limited number of settings, despite the strong evidence that is available for them across multiple countries. And here, the pioneering work that was done in Switzerland, of course, deserves acknowledgement. This includes programs that use heroin or diacetylmorphine, as well as in Canada, we moved towards using injectable hydromorphone because of the difficulties of sourcing a supply of heroin in Canada for these models that unfortunately did not lead to any larger amount of scale-up. Starting in about 2016, although a lot of prescribers have been doing this quietly prior to then, were prescribed safer supply programs. And here, this is the prescription for unobserved take-home dosing of primarily hydromorphone tablets. Hydromorphone tablets are not magic somehow. They were used simply because they were available on the formulary. Which means that they were paid for under our public payer pharmacy system. They also were in many communities where they still had quite a bit of prescribed pills in their unregulated markets, something that people were using and generally did like. I'll also note, and here I'll just make a nod to Alison Ritter's presentation this morning on policy. There was a lot of energy in Australia at the Harm Reduction International Conference earlier this year about BC having a prescribed safer supply policy. And here I will note that it's very much a policy document. It is framed as an enabling document that does not have any specific funding or programmatic support behind it. So it's a bit of an aspirational move in a lot of ways that has not necessarily translated into a lot of movement on the ground towards a framework or a robust system of programs in the province of British Columbia, although it was a little bit of a nice move forward. So I'm not going to say much about observed dosing models because these are what people are most familiar with. I do think that it's important to note here, however, that one of the things that has happened in Canada is we've been able to actually open injectable opioid agonist treatment programs in smaller communities that were often very neglected in Canada. Canada is a very large country, and so often we spend a lot of time paying attention to what's happening in Vancouver and ignore places like New Brunswick, where they now have a very robust injectable opioid agonist treatment program. Also, there's been some innovations in terms of using new medications like sufentanil in injectable opioid agonist treatment programs to try to catch people who have very high tolerances from their exposure to fentanyl from the street supply. In terms of prescribed safer supply, I think it's very important to recognize that in Canada, what we're doing is a medicalized hybrid that was a response to community calls for safer supply, where prescribers who have the ability to prescribe controlled substances use the tools that were available to them to attempt to provide safer supply to people. Again, these programs were very much meant to primarily address the overdose risk that was coming from people using fentanyl from the street supply. It was very strongly an attempt to center a harm reduction philosophy in the care that was provided. And in programmatically, what often they do is they prescribe a long-acting backbone, such as methadone or slow-release oral morphine, and then also provide daily dispensed hydromorphone tablets to people that they can take home and they can use as they wish, when they wish, either orally or by injection. The other thing about hydromorphone, particularly the dilaudid branded tablet, is that it dissolves very completely for injection, so it's quite useful for people who choose to take their medications in that way. In terms of program models, this is where there's actually a huge amount of difference based on where you're located in Canada. Local context matters a lot in terms of safer supply, in terms of what the programs look like. Much of the scale-up of safer supply prescribing in BC happened in existing addiction medicine clinics and providers, where it was integrated into existing practices, addiction medicine practices. Often for people, especially since most of this early scale-up happened during COVID, it was often actually scaled up for people who were already on an OAT backbone, and then hydromorphone was added on top of that. Depending on the clinic, there might or might not be primary care supports or other social supports available. A separate model, which is one that really got current in Ontario, was a model where primary care providers who primarily were working with people experiencing homelessness, a very disadvantaged and marginalized population, mainly in inner city settings, started to actually prescribe hydromorphone tablets alongside primary care. So here it was really safer supply as one aspect of getting people involved in a comprehensive primary care system, and then funding that came in 2020 allowed for really robust wraparound supports to be added to this. There's about 14 of these programs in 10 cities in Ontario with about 1,500 clients. And we often actually don't talk very much about the fact that probably the majority of safer supply prescribing is actually happening by individual prescribers. We hear a lot from people now who talk about how their individual family physician just kept them on their pain meds. And this is, folks, there's such a huge interplay. Anybody who's worked with this population knows that there is a lot of overlap between chronic pain, substance use disorder in people. And so oftentimes this is people who just decided to maintain them on a high-dose opioid prescription, especially during the period where there was a lot of deprescribing that happened and that had a lot of negative impacts on people. What we don't have very much of at all is non-prescriber-based models. Currently in Canada, Safer Supply is a fairly medicalized program model. There's been a strong hesitation on the part of our national regulator, Health Canada, to provide any kind of sanction for a non-prescriber-based model, despite the fact that DULF, the Drug Users Liberation Front, has applied for both funding and an exemption to the criminal code to be able to do this. There's small compassion clubs or Briars clubs that are operating around the country. I just want to underline this unsanctioned model because the people who are engaging in this work are doing so at great personal risk because they are technically trafficking drugs. What they're doing is they're purchasing generally from the dark web. They're testing the medication so that the composition and the dose is known, and that they're distributing them amongst a group usually of local well-known drug users. These are very, very small-scale attempts, and I salute them for their bravery and their courage because we have not been at all brave in moving towards these on a large-scale basis. Yeah. So just really briefly, I just want to end on some of the evidence for safer supply because there is actually a fair amount of it and it's been coming out quite quickly. This is a safer opioid supply review just dealing with safer opioid supply. If you Google ODPRN safer supply review, that's where you'll be able to find it. It will basically summarize everything that I'm about to say, but much, much better. And so it looks at the studies that have come out around safer supply in the last few years, including both quantitative studies that include health admin databases database analyses, as well as qualitative studies and program evaluations. One of the things that a lot of the Safer Supply programs have been doing at the ones that are funded by the federal government is they've been actually putting out quite transparent program evaluations of what's going well with their programs and what the challenges have been, which is actually a really brave act as well in an environment in Canada where these programs are very contested. And there is actually quite a bit of targeting of programs that is often happening. But just to really quickly talk to you a little bit about some of the findings from this evidence, who's accessing Safer Supply programs? As a general rule, it is people with really complex comorbidities, a lot of medical complexities from their substance use, high rates of prior health service utilization, and a lot of folks who've had not just recent, but multiple attempts at OAT treatment. So these are folks who are medically, socially complex, who've been trying different aspects of our treatment system and have never found anything that's managed to stick for them. These are the folks who are generally in the Safer Supply programs, and you can see there some of the really high rates of HIV, Hep C, recent hospitalizations for infectious complications that people have. I know, I'm gonna try. I just want to highlight a few main studies that we've done. This was actually a study that we used health administrative data using London, which is one of the longest running programs in Canada. 82 clients from the London program. Again, very complex people. If you look at the pre-existing conditions compared to the people in the matched cohort group, we had a really hard time matching on some of the main variables like HIV because people were just so much more complex and sicker. And we did, what we did was we decided to look at the year before and the year after people entered the Safer Supply program on some key health indicators, including emergency department visits, hospital admissions, and hospitalizations for incident infections. So Safer Supply folks generally were sicker at the get-go and had much, much higher rates of health systems utilization, and they got a lot better in the year after. Starting on Safer Supply, we saw significant decreases in their use of the health system. We saw no changes in the matched cohort that was unexposed to Safer Supply from the same city. And, oops, sorry, I want to go back. There was one more thing. They also had lower healthcare costs, not including the cost of primary care because we couldn't cost that out. Higher medication costs, which is, again, not something that is terribly surprising, but it should be noted that 15% of the healthcare cost was actually for the opioid medications, with the majority of the medication costs actually from treating all the other medical conditions, which is probably actually going to represent a long-term health savings to the system. So we saw a lot of scale-up of Safer Supply programs across Canada during COVID, 250% increase. We had 2 provinces provide guidelines on how to do risk mitigation or pandemic prescribing, which was Safer Supply prescribing that was adapted to the situation of the early days of the COVID pandemic. And just really quickly, there was some interesting papers published on providing people Safer Supply in COVID isolation sites in order to facilitate their isolation. They all stayed, shockingly, and they had very few overdoses, which I think is actually a really good learning for the broader healthcare system, which in this population, we often see a lot of folks leaving, quote unquote, against medical advice. Well, it turns out if we meet their medical needs, then they stay. And so a lot of really good findings from qualitative research. I'm going to have to wrap up because I can see Julie giving me the side eye right now. So fewer overdoses, very increased quality of life from people who are receiving these medications. The main issues that people are identifying are the need for more medication options, as well as insufficient doses and insufficient program capacity. I really want to just highlight how much there is no increase in mortality that we're seeing from Safer Supply. We're looking at this very carefully in both Ontario and BC, the 2 provinces that have scaled it up the fastest. And I'll just end right here really quickly. It's really important when we're talking about Safer Supply. There is multiple different models right now going on in Canada. Local context is so crucial. We don't have smokable options. And we are not talking enough about, in North America, or at least in Canada, we've seen a generational shift to people smoking fentanyl. It's probably the primary method of administration right now, and we don't have options for people right now within the current Safer Supply programs, and that's a real issue. It's very small levels of prescribing that's happening right now in Ontario. We had in March of 2020 about 500 people. Now it's up to about 1,500 compared to close to 70,000 people on OAT. In BC, about 5,000 people receiving Safer Supply compared to about 25,000 people receiving OAT and about 100,000 people with opioid use disorder. And these programs are very, very, we don't know what's going to happen to them. The long-term funding from the federal government is uncertain. We're moving into a phase where the Conservative governments are actually targeting these programs very, very directly. And so rather being able to have nuanced discussions about the pros and cons of Safer Supply and how they're helping the people who can have access to them and how we can deal with some of the issues that have come about. Instead, we've moved into incredibly polarizing rhetoric that unfortunately isn't going to get us very far in addressing the overdose crisis. And then, thank you very much. Sorry that I ran through that last bit.
Fantastic. Thank you so much. Look, Gillian, I think this is really challenging around how we start to manage toxic heroin supplies and how we move on from the damage that drug control is doing to our community. We're going to go to the next speaker, but maybe some of our Canadian peers in the room, if people maybe want to come and tell us about the DOLF program and about the pressure that DOLF is being put under at the moment, it would be good to have some of that feedback as we move into the question section. So I'm very delighted to introduce Dominic Shorey, who is the head of the Drug Information Centre, DIZ, in the city of Zurich. And this is another personal passion of mine around how we respond to people in dance drug settings and party drug settings. And again, if we're talking about enhanced harm reduction, how do we move on and develop harm reduction beyond the current range of interventions, and drug checking is a key component in that. Dominic, you're very welcome.
Thank you very much for the introduction. The next few minutes I'm going to talk about an overview. I was asked to give an overview about drug checking globally, state of the art, which is quite an issue to do that. Then some words about the evidence, what's known about evidence of drug checking services in general. Then a few current data trends, one on substances, but also on user and drug markets. Then a few lessons we learned in Zurich and challenges that drug checking services are faced with in general. The Drug Information Center is a harm reduction center based in the city of Zurich, Switzerland. We provide harm reduction services mostly for recreational drug users, but not only. So one is drug checking in different settings, one office-based, fixed site. We have also mobile drug checking for parties and festivals. We do counseling, social counseling, but also drug counseling. A lot of inputs and workshops in schools for professional health cares and stuff like that. We also do outreach work, not only in the streets, but also online. I will come back to this a few minutes later. And we're part of the Zurich pilot project about regulated supply of cannabis. So we have right now 100 study participants who are coming to the Drug Information Center, buy their cannabis and get counsel. Just a short overview, what is drug checking? You may have heard about it. There is a lot of data about drug markets. One is seizures by the police, so this is obviously not drug checking. There are systems like amnesty bins. You may have heard of that. When you go to a festival and you won't get caught by the police, you can put your pill in some bin and it's get analyzed in a laboratory, and then they do statistics about what's circulating on that festival. This is not drug checking. Drug checking is the core of drug checking. It's harm reduction for individuals, but also for a broader society, so public health. And the main thing is about drug checking is it's analyzing substances and counseling people to reduce risk, of course, and without judgment of their individual decision to consume drugs. So it's you can never do drug checking counselings in a very paternalistic way, for example. So if you would like to bake a drug checking service yourself, what ingredients would you need? It has an explicit aim of harm reduction, of course. It collects and analyzes samples direct from the public. So it collects samples from people who are using those substances. Then the communication of the result is directly to the people who are handled over their samples. Then drug checking always involves some kind of exchange of information between the person who used the drugs and the professional or the peer who is doing the counseling. And it's really a counseling session between experts. People who are using drugs are expert for their drug use, for their life, and we have some information about safer use, about drug markets and stuff like that, but it should really doing this kind. And then it gives information about the risk to the service user about this specific sample. So you will get the quantified result of your sample, and then we can give you some advice, some safer use advices dedicated, tailored, specific to this sample. I'm not going into detail about how to analyze, but I highly recommend, if you want to open up a drug checking service, to ask some questions. What kind of result do you want to provide? Of course, I know it's a question of resources, especially financial resources, but still, in a very dynamic market for opioids, we heard it, for catenones, for cannabinoids, but also for stimulants, you have to be aware very much of the method that you're using. And usually it's like a combination of at least 2 different methods to have good quantified results. Drug checking globally, we heard a few words about South America. I will not go into detail to that, but as you can see, most of drug checking services around the globe are based in Europe. I would zoom into that map a little bit more. I want to show you this map because in Europe, there is a growing network with a close collaboration, because you all know that drugs, they don't respect national borders. So if you have some trends in some countries, in some cities, it's really, really important for people who are using drugs, also for professionals, to have this specific exchange about sometimes very small trends. I mean, it's not always about like this mass poisoning of fentanyl, synthetic opioids, but if some people are starting to use more ketamine, for example, then that you are aware, okay, there in Vienna, for example, it started, and we are aware of in Zurich or in Barcelona. What about the evidence of drug checking? There is quite a solid evidence for drug checking as a monitoring tool. What does that mean? Drug checking is often seen as ideal for monitoring the emergence of new drugs on the market. So novel psychoactive substances, for example, synthetic cannabinoids, I will come to this back in a few minutes. It seems to be ideal to monitoring those kind of trends. Then drug checking enables tracking new groups of hidden user groups with increased risk more quickly. For example, people who are part of the chemsex scene, for example, that you're really quickly aware of new trends, new substances, and also new risks. And then drug checking enables also the authorities to intervene at the very early stage and more effectively based on a nuanced picture on the drug market. That's what I said. Some trends are very small. For example, in Switzerland, there is a trend among minors to consume opioid painkillers, benzodiazepines through illegal shops. Maybe that's 200-300 persons who do that, but it's a really small trend, and it helps really the authorities, the healthcare system, to be prepared for those kind of trends. There is a bit less evidence for drug checking as a harm reduction tool, meaning the effects on the individual behavior. There seemed some positive impacts of unexpected results on the behavior, also positive impacts of counseling sessions on behavior of people who use drugs. Usually, people say more research needs to be done, more evidence needs to be built. I put a question mark there. I'm a bit skeptical about that. If you really can convince conservative, skeptical people with providing more evidence. I think drug checking is much more about fundamental human rights. It's much more about empowerment, and it's much more about an attitude and a way to deal with people who use drugs than about building even more evidence. There is a study financed by the Federal Office of Public Health 2 years ago. That sounds quite promising. So you can see 75% of participants had more safer use knowledge after the counseling session, which is quite good. 2/3 reported that they have a less high risk use of their substance. 9 out of 10 used less or nothing of a substance after an alert, so after some suspicious, for example, cutting agents was present. And also 9 out of 10 encouraged others to use the drug checking service, which is great because this peer aspect, if people who are using your service think you do a good job, that's the best thing to get in contact. Some spotlights on current data trends, what we see in drug checking services. Increasing purity of cocaine, a very, very dynamic market for NPS, especially synthetic catenones. Also very dynamic market for cannabis, and the digitalization of the drug market. We'll go a bit into detail of those 4 kind of trends. As you can see here, and this is not only, this is data from the city of Zurich, but it's a similar trend in all other drug checking services around Europe. So it's a clear increase of the amount of the purity of cocaine in cocaine samples. As you can see, I checked the numbers just yesterday. By the end of this year, we will reach around 90% purity as a mean in all cocaine samples. And we test almost as much samples in the city of Zurich as all forensic labs in Switzerland do together. So I think it's, we can say a little bit something about the cocaine market. On one hand, this might be good because a higher purity means less cutting agents, especially pharmaceutical active cutting agents. But of course, it also means a greater risk of overdose, especially if the amount is unknown. And another problem that we have, I was talking about the mean, but we have also samples with, for example, 1% of cocaine. So we have a high range of cocaine amounts, so this makes it extremely difficult for people who are using cocaine to dose it without a drug checking service. And despite the high average proportion of active ingredients, 25% of all samples contain some kind of pharmacological active cutting agent. This means we don't quantify non-pharmaceutical active cutting agents like sugars, like milk powder, stuff like that. Similar, what you told us, phenacetin, often present, also local anesthesia like lidocaine, you showed it too, and some other contents. Then, about 1.5 years ago in Europe, the market for MDMA changed a lot. It started with people who bought their substance and thought it was MDMA. And in fact, there were some synthetic catechins inside, like 4-CMC. So you can see 3 examples on the left side, which is supposed to be a bit more neurotoxic than other catechol derivatives. Then in the middle, you can see now it's completely random. You want to buy some synthetic catechol, you want to buy some 3-CMC, in fact it's 3-MMC, you want to buy some 3-MMC, and in fact it's 2-MMC. We can code almost through the whole alphabet. So it's almost impossible to have any information about what exactly you are consuming. And the problem of all those NPS catechol derivatives is you have obviously no studies about long-term side effects, for example, because they are present on the market for a couple of years only. The cannabis market is even more concerning. About in 2019, we received a lot of samples of people who bought cannabis on the legal market. So they thought it was THC-rich cannabis, but in fact it contained some synthetic cannabinoids, which was sprayed on low THC, so-called CBD cannabis, as we call it in Switzerland. Then, about a year ago, the market got completely random. As you can see on the right side, we have a lot of semi-synthetic cannabinoids like HHC, like delta HTHC, also edibles containing some semi-synthetic cannabinoids with very, very unpleasant effects, and it got quite of a lottery for people who are smoking cannabis, and this is quite concerning. The industry is quite creative, and also for the lab, you can imagine that for analysis, for laboratories, it's quite difficult to always be updated. Another thing, every person who is coming to a drug checking service is asked, where did you buy your sample? I mean, not the address or the phone number of your dealer, of course, but just in a more general way, did you buy it privately, for example? Did you buy it on a party? Did you buy it through digital channels like messenger services, like darknet shops? Did you buy it on the streets? Or did you produce it yourself, for example, for cannabis or mushrooms or stuff like that? And you see an increase over the past few years about people who reported that they bought their substance through digital marketplaces. Digital marketplaces look like this. On the left side, you see an example from a darknet shop. We're also present in those kind of shops, just for one hand for monitoring reasons, but on the other hand also to get in contact with people who are using those kind of shops. On the left side, you can see it's very, very professional. It's easy to do. I will not instruct you how to do it, of course, but you see it's similar to an Amazon shop. You have a user feedback, you can give a 5-star rating to your dealer, and on the right side it's an example from a Telegram shop from Switzerland, which is quite active right now. And what is really interesting is, I'm not sure if you can read it there, but there is written in red where you can buy some opioid painkillers, and mostly benzodiazepines. Don't mix it with alcohol. So you can see dealers are putting safer use messages within their shops, which is, from our perspective, quite a good thing. So what have we learned in Zurich? Drug checking services need constantly adapt to realities on the drug market. We don't like to talk about hard-to-reach population. We want rather talk about hard-to-reach services. For example, when we see that minors are starting opioid painkillers by benzodiazepines, we have to open up our service to minors, of course. That's an example. If we see that the drug market is getting more and more digital, then we need to be present also in digital marketplaces. If we see that people are consuming steroids, we need to adapt our service or laboratory and start to check steroids. Another lesson that we learned in more than 20 years of drug checking in Zurich is that there is a cross-interaction between insights in the drug market and safer use communication. We learn a lot about the drug market, about effects, about user reports, and then we can constantly adapt our safer use messages to people who are using those kind of substances. Another thing, an integrated service is crucial, so we don't think that an isolated drug checking service is a good idea, so it's always good to have other counseling possibilities, social counseling, drug counseling that goes further than just this short drug checking counseling service. And then this in-depth insight into market realities builds a lot of credibility with other organizations. We have a lot of exchange with forensic labs, with the police and stuff like that, and we are seen more and more as to be credible, to give information about what's going on the drug market. And I would say personally that drug checking is a good tool in political discussion to shift away the discourse from moral discussions to a pragmatic discussion. It doesn't matter whether you think that a drug-free world might be good or a bad thing. The reality is that people are taking those kind of substances, and we need to have answers to the reality and not to moral beliefs. And I would say also drug checking can change the narrative about drug use. I just wanted to give you an example. If you hear the term very stigmatizing, biased also with some racist pictures concerned, if you hear the word dealer, just think a few seconds about it. What do you think? We are sometimes confronted with the question whether drug checking is a dealer service or not. I mean, by the law, we cannot do dealer service, but in fact, 90% of our people who are visiting drug checking service, by law, they are dealers, because nobody is going to buy 2 pills of MDMA and takes one to the drug checking service and swallows the other one in his bed. Usually it's like you're going to buy 30 pills, sell it to your friends, and one of those pills you're going to check in the drug checking service, which is a good thing. But so you can really challenge those kind of a bit weird concepts about, for example, dealers. Challenges, of course, funding. I would say we in Zurich are one of the most innovative and also one of the biggest drug checking services all over, but the reason why is not because we're smarter or better than other organizations. It's just mostly a question of funding, because we have the resources. So for most drug checking services, this is a huge challenge to get enough funding. Then facing with abstinence-orientated, prohibitive narratives. If you want to prove that drug checking reduces drug use, for example, then you're on the wrong way. I mean, it's a false image that people mostly have. And then building evidence, already talked about that. Legal framework in most countries, also in Switzerland, possession and use of drugs is still forbidden. And this puts sometimes question for professionals who are working in drug checking service, how I'm going to handle with those kind of substances, that they're going to hand me over, do I have to put it where, stuff like that. The legal framework is a huge challenge in most countries, I'd say. And then the trust building with people who are using drugs, especially if you enter new subcultures, new scenes. That's a huge challenge because trust is a tough thing to gain, and it's easy to lose if you make mistakes. If people think it's not anonymous, for example, then you're going to lose that. It's a constant challenge. So a few take-home messages to finish my presentation. Drug checking is empowerment of people who are using drugs. Drug checking is destigmatizing all those false images that we have. Some have of people who are using drugs. Then drug checking is monitoring of the drug market, but not from a police or forensic side, really in real life. What is going to happen in real life, people who are using drugs. And then drug checking is a good way to shift drug political discussions from moralism to pragmatism, I'd say. And at least in Europe, there is a growing importance and also acceptance among politicians, authorities for drug checking. Thank you very much.
So, Dominic, thank you for a really informative and thoughtful presentation. Really highlights this idea of enhanced harm reduction, or you called it full spectrum harm reduction. This idea of harm reduction is an evolving response to the changing drug scene that is constantly negatively buffeted by drug control. I think we've heard really 3 fantastic speeches taking us into this new generation of what harm reduction means. So the response to people who use stimulants, the safe supply argument, and then also this role of drug checking. Just in terms of drug checking, in the Global Drug Survey, 30% of people acknowledged that they had taken a white powder in the last year without understanding what it was. Now, I think that just raises a whole set of risks that we're just, with all the goodwill in the world, you think what you're taking is what you're taking, but often it's not. And the slides on the contamination of the cannabis scene is just like, oh my God, not even plants can we keep in control these days. So, anybody who would like to ask a question, make a comment, please indicate, and particularly our friends from Canada, please, if you want to kick in on the drug user stuff, that would be great. Jason.
Cool. So first of all, amazing presentations from all of you. So thank you so much. To fit so much information into a short period of time is fantastic. My first is a comment for Dominic, and I think, I get your point about the need for research, and I know you're being provocative, but I think it's just so critical. The work you're doing is so amazing and cutting edge in terms of, and maybe some of the other organizations in Europe. And I just think that continuing to document this and provide the evidence for other places is just so crucial to be able to sort of advocate for this, because they're not, they don't have the evidence, and they'll need that to then advocate to set these facilities up. I know you're being provocative, but I think it's just really critical, and you guys are doing amazing work. My question, I was fascinated, and maybe it's because I'm not in Europe and I didn't know that this was happening, but in terms of the increase in the purity of cocaine that you're seeing, I was just sort of curious, has there been an increase in the price of cocaine as well? So this has been happening in the absence of an increase in price. Do you have any clue through discussions with EMCDDA or other global sort of organizations to understand what's the reasoning for why the purity is increasing? Is it a change in the drug markets, where the drugs are coming from? I'm just fascinated by it. Press one.
Maybe also a question to... Okay. Maybe also a question for you, but as far as I know, there is a record production of coca leaf in South America, so the product is there, and you only put cutting agents inside if you need to. I mean, the concept is not to put as much cutting agents as possible, because it's just a question of price, and if you have enough cocaine on the market to sell it, I mean, why would you do that? I think that's the main reason for, because it's really in all European countries the same thing. Don't know it for North America, but for Canada or... Yeah, go ahead.
Yeah, just really quickly, because I asked Ernesto this while you were presenting on that exactly. We've seen a similar phenomenon across a lot of North America as well, where the quantitative drug checking is showing cocaine in the 90% range since about 2020 as well, with no real change in price. Mm-hmm. So it's just interesting that it's happening in both places.
I'll add to that. I think first of all, it's there's more cocaine producing in Colombia and the cocaine producing countries. First of all, that means that the war on drugs is not working. No, we have even more cocaine in the market. No, but the problem in Latin America is we don't do drug checking. No, so we don't know the quality. I'm a cocaine user myself. I could say the quality varies from each seller. No, so we have good cocaine quality in Latin America because it's really close to the source, but it's really interesting that we get in this. No, so definitely thinking on an illegal market, sellers are taking care of their clients. It's a great thing to think about on harm reduction.
And just to say, I wish in the UK that was a problem. It's not a problem that we're facing. We're having peers reporting to us Levisol necrotitis, which is a skin condition from the cutting agent within cocaine. So the cocaine is so cut that we're now getting people with necrotitis from the cutting agent in cocaine. So again, really highlighting the impact.
So thank you. Maybe a question here for Marie-Ève?
Yeah, hi. So I'm Marie-Ève. I'm OAT and a safer supply prescriber in Montreal. And I guess my question is a bit philosophical. I would like to hear from you. What would you say is what's next, or what should we be advocating for, in the sense that I've been advocating and prescribing safer supply. I'm trying to increase the dose. I'm trying to help my people not to die, but still they're dying. I really feel it's been, I think, one of the first time I really feel I'm losing the battle. And I'm not sure if we are focusing on the right thing now. So that's an open question for you. Should we talk now about drug policy? Should we talk about poverty, about housing, or because I feel if I spend too much of my energy and my time talking about EPSI or safer supply or whatever, I'm not targeting the big picture and my people will keep dying, and I feel time is running now. So I don't know, I would just feel like having this discussion with you and having your head on it.
I mean, maybe I'll start. It's an absolutely excellent question, because I think in Canada right now, the reality is we're seeing intersecting crises happening at the same time. It was better recognized during the COVID pandemic, and we had a lot of talk about the dual public health crises of COVID and toxic drug supply. But right now in North America, I think broadly as a whole, Canada in particular, most of our major cities, the affordable housing crisis is ridiculously intense. We can't house people. We're seeing encampments that are just going on and on because there's no housing. Our shelters are all completely full. There's no level of government that's willing to actually do anything about it. Our levels of social assistance are literally about a quarter of what it would take to even rent an apartment if you were putting your whole social assistance check to just your rent. And so we're really having this, dire, devastating poverty crisis, affordable housing. Whenever I'm talking to policymakers, I keep on saying, we can stabilize people's health to a certain extent with safer supply. And some of the initial research is showing us that that is, in fact, possible. But there's an extent that we can't go beyond when you've got somebody who's living in a tent and pooping in an alley and has trench foot all winter. Now most of my safer supply colleagues treat trench foot as a regular matter of course because of just how entrenched the homelessness crisis is. I'm now talking to people who've been absolutely homeless for 2-3 years and are starting to feel like there's no way they're ever going to get housing, and it actually looks like they're probably correct. So again, I think the flip side of this is, and this is my real worry right now, is that we're moving into a place where the toxic drug crisis is getting conflated with the affordable housing crisis. So I think we're going to start blaming a 25-year massive reduction in the social safety net on toxic drugs, rather than really talking about the fact that we have gutted, in Canada anyway, our social service sector and our social welfare net to the point where it's basically non-existent. There was an article yesterday that came out because at the Canadian Addiction Medicine Conference, which is happening right now, they just released their guidelines for doing medically assisted death for people with substance use. And so we're actually talking about introducing, you know, and I'm a very strong supporter, having had this happen in my family recently, of medically assisted death, but we're talking about introducing medically assisted death solely for substance use, rather than actually talking about a comprehensive housing program and poverty relief measures and making sure that everybody can live, you know, their highest quality of life. Like, I feel like sometimes we're in a bit of an alternate reality moment right now.
Yeah, we might, maybe one of the things in Canada, and I will move to a question here, but maybe a thing that we have to acknowledge is the polarization and the backlash. And we might also want to take a step back and think of how we take this on and provide, you know, the research agenda that will help us move forward in a direction that is evidence-based, so that we don't, because now we've been in the emergency and there was, as you said, zillions of things happening and no definition and no nothing. And I think this is harmful in a way, because then we might have a political backlash that would be very important. I think we have to acknowledge these things as well. So we have a question here for you as well, I guess, or maybe for everybody. But can you speak to any youth program available in Canada or otherwise as a pediatrician, actually about the initiation to drug use and also maybe the consequences of those exposures?
Yeah, no, so there's been a lot of concern, and I think the polarization that you're talking about, there's been a lot of concern about youth initiation to drug use based on having a wider supply of hydromorphone tablets in street markets diverted from safer supply programs. So there's a couple things here. One is that safer supply prescribing is very, very small scale. 95% of the hydromorphone prescribing happening right now in Canada is actually happening for pain. It's not actually happening within safer supply. So we don't know where these medications are coming from. There's always been pills in our unregulated markets. That's not a new thing. We deprescribed massively. They didn't actually go away. And so again, I think it's like this overall failure of prohibition-based approaches that we have to actually take a step back and examine more broadly, because kids do drugs. And so I think the question is, I mean, do we want them initiating into a market that is fentanyl? Because the conversation that I don't see us having is the fact that kids smoke fentanyl. I mean, people take pills, kids take pills for sure when they're available, but we've seen a generational change. As an ethnographer who spends a lot of time in the community, we've seen a generational change in the way that kids are using drugs. They are smoking fentanyl, they really like smoking fentanyl, and interestingly, compared to heroin, they're not transitioning to injection. I know kids now who are in their 20s who have never injected, and they've always just smoked because it's so potent. We're not having a conversation in Canada about how do we actually have measures for those kids. And so again, I think that sometimes when we're talking about polarization, we're actually talking at cross purposes, because we're not really talking about what's really happening. Instead, we're often in the realm of moral panics, which I find very unfortunate.
So Ernesto's going to make a comment, and then we're going to go to a question up there from our Canadian peers.
I just want to add, because I think it's a really important question. I think something we have to address as soon as possible. No, underage people using drugs. This is a taboo subject. This is even a taboo, I don't know how to say that, yeah? A subject. No, we have to deal with people who underage or minors who use drugs. You said it really well, Dominic, you just said it. I just make an example. Costa Rica has a drug policy, a harm reduction national model, so it's a public policy. It doesn't include underage people, no? So we are not included minors in harm reduction projects. So for all INSU members and boards, no, I think it's a matter to take into account for the next conference in Athens.
Thank you so much. Amazing presentations.
I think I want to move away a bit from safer supply and talk about the global picture. So I think there was a heroin shortage in Europe when Taliban took over in Afghanistan in the 2000s. I'm wondering if you've seen a change in your drug market since they retook Afghanistan. Have you seen any drop in opioids because they're decultivating opium poppies and all of those things? Have you noticed that in the European market?
But I think it's a bit early. I think that what happens, I mean, we know that the Taliban have destroyed about 80% of this year's crop, so that's going to impact next year. I think we're all really worried about, in fact, my peer team were telling me that we've got a drought going on of heroin suddenly in our local area. I don't think that's linked to I think it's probably more linked to local arrests rather than the macro level. We are all super scared that we could be on the edge of a synthetic opioid crisis if the Taliban, if their real cut down on the supply does go on to impact on the global market. No, 85% of our heroin in Europe comes from Afghanistan. So this is a potential catastrophe in the waiting. And I think some of the partnerships we're looking at with the Canadian drug users is to try to say, how do we learn from what your guys are doing in North America to learn that? Dominic?
Just in addition to that, we started 3 weeks ago in the city of Zurich with building up some kind of emergency plan because we don't know, it's too early, but we know some of the answers right now, and we will very quickly also get in contact with other cities, with other organizations, as far as we have some ideas about how to handle a possible opioid crisis in European cities.
Gillian, this is a question for you. Benzodope and xylazine, and I didn't hear really much about it because as far as I know that all the street dope is cut with benzos and xylazine is on its way. Yeah, for starters anyways.
Yeah, no, and I think that this is, I mean, again, if we need more evidence and more emphasis on the issues with an unregulated market, in North America, the genie's out of the bottle. We're going to continue to see these mixes of different synthetic fentanyl analogs, the nitazines, the xylazines, the benzos. I think one of the interesting things to me about it is that it really does differ in terms of, if we look at drug checking in Toronto versus some of the drug checking in Vancouver and Victoria, you do see it pop up differently in different places. But again, I think that this really, really speaks to the difficulties of prescribed safer supply. It's very similar to what Dominic was talking about when you see those, THC and the MDMA up there of the different forms. I mean, this is a consequence of prohibition, and until we start to actually think about regulation so that people can know what they're taking, and when they're taking, and there actually is some consumer choice in the market. When I in Canada want to buy cannabis and I go to the legal regulated cannabis store, I have a choice of different types of cannabis at different concentrations. I don't know why we're not talking more about the fact that that's actually a really, really good thing. Yeah.
Matt, do you want to say something
what
as
about
well?
the prescribing? Like if you go to a physician and you tell them, okay, I'm wired and to fent and benzo, and they won't give you benzo. And the other piece is Dilaudid does not measure up to fentanyl.
Yeah.
It does not by miles. So a lot of it does get diverted, and in essence, they're just Band-Aids.
Yeah. And I think that Dilaudid works well for people who that was their drug market, right? And that was their drug of choice in places where prescription pills were really, really prevalent. But you're right, we hear all the time about the low doses. Interestingly, in BC, the number of Dilaudid's prescribed is quite a bit lower than in Ontario, where we are seeing, it seems, some stronger effects from the programs. And you're right, I think that The conversation we're not having, again, because of this polarization, is how can we support the prescribers who are actually trying to figure out how to help people? How are we supporting them to be able to do this experimentation around, okay, is there a way to actually catch somebody who's had heavy exposure to benzo dope? Because right now that's a very, very difficult thing for prescribers to do, because there has been attention from colleges, there's been attention from colleagues in addiction medicine that makes it very, very difficult for people to feel, even those who want to actually be working in a very client-centered way, to be able to figure out how to meet people's needs.
Maybe I can, this is a very interesting and Canadian conversation in a way, but as a Canadian and a physician and a prescriber of Safer Supply, I think what we begin to see emerging also is that Safer Supply is a part of the big puzzle. And then we kind of have to make some definitions and some understanding a little bit the roles of each of everyone, and probably as a prescriber of Safer Supply will need some much more guidance, and another way when we're talking about policies, legalizations, and all these things, it's probably not the Safer Supply that will solve the issue of the overdoses. And I think in Canada, these things have been very polarizing, and I think maybe it's a lesson for the rest of the world. But on the other hand, what's the natural experiment in Canada, if we do it right, at a pace that is probably much, much more slowlier than what happened in the past 2 or 3 years, we might help the field advance both harm reduction but also treatment for people who use drugs. Because I think treatment has been a bit evacuated in this discussion, and sometimes it's at the detriment of the people who want the treatment.
Julie, it's an amazing point, because I think right now the discussions that we can be having, because as I was mentioning, Safer Supply looks very different in different contexts in Canada. I think the interesting thing that's going to come about in the next few years is these research on which program models, where, how do they work, who are they reaching. Right now we're reaching a really complex group of people who have not been in contact with the medical system. That's good for some things, but it's not necessarily going to help your occasional drug user or your person who doesn't feel like they need treatment. And so again, I think that we're really moving into this moment where hopefully we can start to have discussions about what a continuum of different options look like, both medicalized options, treatment for those who want it, as well as non-medicalized options, because not everybody wants to get their dope from their doctor, is the other thing that we hear very frequently as well when talking to Safer Supply clients. Mm-hmm.
Great. Look, this is a fascinating conversation, and for me, I could carry on for another couple of hours having this conversation, but we're running out of time. I just want to ask all of our speakers, I'm giving you a warning now as well, but I'll come to you last. Just to maybe just think of, as you close, we're talking about enhanced harm reduction, we're talking about full spectrum harm reduction. What would you see as the next area of innovation in your sector? So stimulants, drug checking, Safe Supply. What should we do next?
Well, I've said it several times during this conference now. We as drug users in Latin America usually don't inject. There's almost no opioids, even though Colombia and Mexico are heroin-producing countries. And we think harm reduction, how can manage to deal with this population, how HIV and hepatitis C also integrate with people who don't inject drugs. Stimulants guidelines, well, Monica is gone, but I think it's a great step to go forward to it, but it's definitely, if we want to do that, at least in Latin America, in our context where the drug war, its presence everywhere now with this policing and judging and constantly oppressing towards our community, we need to address the stigma and criminalization. So decriminalization and definitely regulation should be a process, because these are also harm reduction interventions.
Concerning drug checking, focus more on drug consumption rooms, be as low threshold as it's possible, and last but not least, contribute to that prohibistic, abstinence-oriented discourse about drug use, and try to help changing the pictures that we have about drug use. I'm glad that at least one person reacted to my provocation about the evidence question. So, but rather contribute to this discussion about all those false images about drug use, and that drug checking and harm reduction in general is about fundamental human rights.
Yeah, so just really quickly, I think for safer supply, we're not talking a lot about stimulant safer supply. We don't have a lot of smokable options available, and we really need that. And I think that one of the dangers of safer supply right now is it's very much a medicalized option for people, which does meet some people's needs, but we need to imagine safer supply as bigger and as a larger regulatory project, rather than just focus on these medicalized options for folks, which again, are quite important and serve an important purpose, but aren't the be-all and end-all.
So thank you very much all to stick with us, and thanks for the amazing speakers and the great discussion, and up to the break, I guess. Thank you very much.